In 1999, a 14-year-old girl of Turkish origin presented with vertigo and generalized tonic-clonic seizures. Magnetic resonance imaging analysis showed multiple hyperintense lesions in T2-weighted images, which included bihemispheric periventricular white matter, frontal cortex, left insular cortex, and left brainstem. A symptomatic treatment with valproate was initiated in 2002, 3 years after onset of central nervous system inflammation. A mild thrombocytopenia of 110 times 10 to the third cells per microliter occurred for the first time, but no further diagnostics were carried out. In the next years, she experienced various neurological symptoms such as hypoesthesia, weakness of her right arm, vertigo, and double vision. These relapses occurred in a frequency of 1 to 6 events per year. MRI analysis showed a slow progression of inflammatory gadolinium-enhancing lesions, mostly localized in subcortical and periventricular areas. Conventional angiographies revealed no signs of vessel stenosis, sinus thrombosis, or any signs indicative of primary CNS vasculitis. Under the assumption of a relapsing remitting multiple sclerosis, these clinical symptoms, as well as future relapses, were treated with intravenous steroids until 2011. After our patient's first presentation to the clinic in 2011, an extensive clinical reevaluation was performed due to increasing doubts concerning the initial diagnosis of multiple sclerosis. Analysis of cerebrospinal fluid showed lymphocytic pleocytosis, intrathecal synthesis of immunoglobulin G and immunoglobulin M, impairment of blood-brain barrier integrity, and positive oligoclonal bands. A differential diagnostic included serological, microbiological, and virological analysis from both her blood and CSF revealed no signs for a systemic vasculitis, infection, or any underlying specific autoimmune diseases. After another relapse presenting with unsystematic vertigo, we ultimately clarified the nature of her inflammatory leukoencephalopathy by performing a brain biopsy. This showed severe perivascular inflammatory infiltrates as well as diffuse cellular infiltration within the parenchyma. The infiltrates were dominated by small mature CD3 T cells and high numbers of CD138 plasma cells, whereas only low B cell numbers could be observed. A diagnosis of Evans syndrome is a rare hematological disease commonly defined by the combination of simultaneous or sequential autoimmune hemolytic anemia and immune thrombocytopenia, sometimes associated with neutropenia in the absence of known underlying etiology. Based on the detection of CD20 B cells and CD138 plasma cells, both by flow cytometry assessment of our CSF and by immunohistochemical stainings, we initiated treatment with anti-CD20 monoclonal antibody rituximab. This treatment regimen could be beneficially used in CNS inflammation and has already been reported to be effective in cases of Evans syndrome. The prognosis was Evans syndrome.